Hello and welcome to Chief Among Friends. I'm your host, Dr. Chris Hobson, the Chief Medical Officer at Orion Health. On this podcast, I chat about topics ranging from technology priorities to new innovations in integrated and coordinated care to healthcare sustainability. You can follow the conversation on hashtag Chief Among Friends and be sure to follow me on Twitter at Dr. Chris Hobson. Interoperability continues to be one of the most talked about topics in health IT and is tricky to say the least. It requires a number of things including senior management support, a consistent strategic approach, agreements to cooperate by sometimes reluctant partners, robust standards and somewhat complex technologies. In the US, ONC and CMS have made a strong push for increased use of interoperability, with many initiatives including TEFCA and the US CDI, as well as the data blocking prohibition rules. We have not seen the same intense drive in Canada, though certainly Canada Health Infoway has invested heavily in promotion of interoperability standards. On the industry front, vendors are supporting enabling technology such as FHIR APIs to improve interoperability. Still uncertain is how much effect or impact FHIR will have in the real world of healthcare. Today, we're fortunate to talk to my friend Matt Maennling, an expert in health IT interoperability, for his advice, perspective and recommendations on interoperability. Welcome, Matt.
Thank you, Chris.
First off, how do you define interoperability?
Simply put, interoperability is the ability for different information technology systems and software applications to communicate, to exchange data, and to use the information that has been exchanged in useful ways. So being more concrete, it's simply that those systems work together so that a clinician or a care provider can make sensible data-driven decisions when they need to make it using the most up-to-date and standards-based data. Now, HIMSS has been very useful. This year in March, they provided a stratified definition to give people a sense for how far along the continuum of interoperability that they may find themselves. Most basically, foundational interoperability is that two systems can exchange some information, but that there's no interpretation on the receiving end. So think about this as somebody has delivered you a newspaper to your house, but they don't know what is in the contents of the newspaper. Whereas structural interoperability, really, that defines the format of the data exchange, so how the data will come from A to B. And it also describes the data in a way that's standards-based and ensures that the data exchanges between the IT systems can be interpreted at the data or field level. Now, I would say that HIMSS extends that to say that really the gold standard is semantic interoperability. Now, this describes a situation where at the highest level, the ability for both systems to exchange information in a predictable format and to use that information which has been exchanged to enable the receiving technology to do things like provide summaries, reports, graphs, to drive decisions on behalf of a provider to provide more useful data, and fully use that data in care coordination and in clinical decision-making. What's important about that is that the clinician at the semantic interoperability level, the clinician can take faith that the data is authoritative, it's standards-based, it's reliable, and it's repeatable. Now, I have to applaud HIMSS. They extended this to include a concept called organizational interoperability. And this is really stepping a little outside of the concept of technical interoperability to say that organizations need to meet with each other and make conscious decisions about how they can exchange information, alerts, reports in useful ways to help improve quality of care, but also to drop some of the costs out of our system through eliminating redundancies and other waste in the system. So that's a fascinating look. You can be technically interoperable, but maybe not have the best cooperation between organizations. And I think that's a useful extension.
That's very interesting. So let's assume that we have all of the levels of interoperability, organizational as well as the technical and semantic levels of interoperability. what's the promise of this? Where is this taking us? What problems will it solve?
That's a great question, Chris. At its foundation, we need to ensure that we have a complete patient record. Mm-hmm. And further to that populations of patients can be assembled in a set of clinical records so that decision makers, care providers can make useful decisions that are clinically accurate. And so to give a few examples of that would be when there's a complete record and it's shared with the entire care team, and that could include clinician, patient, a substitute decision maker. It could include an allied healthcare worker, like a social worker or a foot care nurse. When information is seamlessly shared in care coordination, you can do things like an electronic care plan, where more than just one care actor is involved in the episode of care. And that collaboration can mean that we can synchronize the care, so align, for example, a visit to a specialist with a follow-up care by a nurse practitioner, and have more complete care for that patient rather than doing things as individuals in isolation. Very exciting in the hospital setting, when a patient is discharged, a good quality e-discharge provides opportunities to ensure that scripts are filled at a pharmacy and that the general practitioner is aware that a script has been ordered. And also that for example, if an elderly patient is discharged, that perhaps their son or daughter is involved and gets an alert and knows what has happened at the hospital and also now what follow-up care that they need. From an electronic health record and health information exchange perspective, if we have a complete authoritative record, when a patient moves from care setting to care setting, their patient record follows with them. So if you go, for example, from a hospital bed to a long-term care facility, it's very helpful for the nurses and doctors on that ward to know exactly what's in your patient record so that they can tailor care for you. So these are just some examples, but what is the ultimate aim? We'd like to avoid readmission to hospital. We'd like to reduce the cost for exacerbations of chronic diseases. And by having complete information, it gives our providers the best opportunity to do just that.
So it sounds as though it would be very helpful for team-based care and for population health, as well as for individual care instances. That's very interesting. So one use of interoperability is to build an integrated platform. So tell me more. What is the place and value of an integrated platform, perhaps as opposed to just exchanging data?
That's a great question. We think of a piece of software as a platform, but really it's not. It's simply one point of data entry and one point to view data. A platform, on the other hand, is a set of tools, a set of software applications within and sometimes without an organization that in unison are what we use to make clinical decisions. So, for example, if we have labs, radiology, we have general practitioners' notes of care, if we have scripts from the pharmacy all rolled up in one view, essentially that's a platform. Well, first you need to be able to store the data. You also need to be able to ensure that before you store it, that it's aligned to standards and that it's aligned to clinical nomenclature. And you also have to make sure that it's able to be extracted or viewed or exported or sent on to the next user in seamless ways. We don't want to get bogged down and have data only available to a certain number of users. So this isn't just about sharing a discharge summary through an email. It's really about adding to the collective longitudinal record over time and making sure that as we add to it, is easy to use, it's authoritative and current, and also gives clinicians exactly the information they need. I'll use a concrete example to close on that point. For example, we know through research that atrial fibrillation patients who are discharged from the hospital, if they simply get the script at point of care by the ED physician, they're 70% more likely to be on that blood thinner 6 months after the episode. Whereas if we discharge that patient into the community care without a script, it's only 30% likely that they followed up with their GP and that they actually got a blood thinner prescription. So how does this relate to a platform? An integrated platform would mean that every actor who's responsible for your care has the information that they need at the time that they need it in the most relevant, structured, and authoritative way.
I like that. So for the next question, so in a recent survey we did of interoperability, privacy issues and data blocking were listed by various health IT participants in Canada. Privacy and data blocking were listed as significant barriers to interoperability. Do you have any thoughts about privacy and data blocking and the role that those might play, either enabling or hindering our ability for seamless interoperability?
You know, it's an interesting question because in many respects, we have very good privacy controls over particularly healthcare information technology solutions. Mm-hmm. We typically have role-based access, we have masking, and we have the ability to put patients in increasingly more sensitive contexts within the software. Mm-hmm. So the real issue that I see is that often, ironically, we are so concerned about this concept that we fail to make pragmatic sharing possible. And so in a more litigious environment like in the United States, data blocking has been such a big problem that rather than take a risk of sharing, an organization has decided we're not going to share anything. And that's an impediment to care because it creates blind spots for a physician or a specialist when they need to make decisions in real time. So interestingly, this is a case where you have patients in their home probably getting many answers from Google or WebMD or other online sources, but ironically being blocked from accessing the data that first of all, under legislation that they own, and second, that their GP is simply a steward of. So I think it is a problem, but it really is driven by incentives and legislation. Right now, a very simple missing incentive is that many physicians in Canada, there's no billing code to simply interact with the patient by email. And so the concept of sharing a bit of information through email or SMS or some other structured way just simply isn't covered under billing codes, and so it's not being done. So sometimes the impediment is not so much technology or legislation as much as the practicality of how do we add incentives for a physician to actually do this.
That's very interesting. Yeah, I can definitely see the role of incentives changing behaviour as well as the technology and all these other kind of finer points that we like to discuss. Following up on your question, on your point about patients, so do you see patient requests for access to their data helping or playing a role in the drive for improved interoperability?
This is something I'm passionate about. I think what's missing in our policy framework is the concept of a patient digital bill of rights. And by this I mean that since it stands to reason that since a patient owns their data under the law, and since healthcare providers are simply stewards of that data, then it stands to follow that a patient should have reasonably unfettered access to their data. Now, we often take a little bit of a parochial view of this and say, well, you know, some of the data is difficult to understand. And a great example you and I discussed earlier today was radiology reports, which are very notoriously difficult for a patient who's not clinically trained to interpret. And sometimes some of the syntax can be alarming. On the other hand, if we're too parochial and too protective about the data that we share with the patient, we're really not enabling the patient to take active control and care and become engaged in their own care. So a concrete example of that is simply knowing that I've got a blood pressure reading that's a little out of range, and seeing that as an anomaly against my graph, which has looked fine for months and months, but suddenly it's trending up. Reasonable people can draw reasonable conclusions from data and information. And so I would march myself down to the GP and probably take action. So we may be overprotecting patients by withholding information, But I suspect it's also that many of our healthcare IT systems simply aren't ready to provide that access to patients. And so I look at patient portals and other healthcare apps on the phone as being first forays into this information sharing. But I think we can be a little braver in this point.
Excellent. So taken as a whole, do you see room for optimism regarding interoperability in the future? Are we making progress, solving problems, and improving things?
I think we are. I'm excited about the concept, building on the last question, of data portability, that the patient's record should travel with them in very simple and easy-to-use ways, whether it's on a phone, whether it's on a thumb drive, whether it's a portal that they can access. We have all kinds of systems that give you access to your tax returns and other financial information. It wouldn't be much of an extension to add clinical data to that. I'm very excited with regard to interoperability with emerging and new standards such as FHIR, which is the Fast Healthcare Interoperability Resources specification. This changes the philosophy of interoperability from individual integrations that are time-consuming to build, a little bit fragile, sometimes error-prone, and moves it to a system where we acknowledge that a system or a software solution could be a source of truth, and that system or source of truth provides access to the external world through a set of services, an API, that allows people to read and to write from that source of truth in order to get the best quality possible data that's available at any given moment. So FHIR is very quick to deploy. Release 4 is important because it's the first version that has components reaching the point of being normative. In other words, the specification is considered stable. It's ready for live production use. And we're seeing proof of concepts being built far more quickly because you're subscribing to a service rather than having to build one integration point at a time, which is very time-consuming and costly. This has the opportunity to make healthcare IT solutions more interoperable more quickly, take time to market and reduce it, and also to make it less expensive to integrate into some of these larger hospital systems or jurisdictional health record systems. So that's very exciting, and it's built on the legacy of existing mature standards like Health Level 7 and other healthcare data standards and interoperability standards. So the future's bright, and we need to be pragmatic in both our legal, our technical, and our clinical decision making.
Very interesting. I'm feeling excited about the future of interoperability. That was a great discussion, Matt.
Thank you, Chris. I appreciate it.
If you'd like to join us for future episodes of this podcast, please follow us on #ChiefAmongFriends and on Twitter at Dr. Chris Hobson.